Continue, please.
Sir, yes. Uh,
I already done this slide. We'll continue this.
yes, sir. Next is oral cavity. The oral cavity is made up of the lip, upper and lower gingiva, buccal mucosa, hard palate, floor of the mouth, and oral anterior two-thirds of the tongue.
So what are the contents of the oral cavity you should be keeping in mind about these things, about the oral cavity? So what is that it is made up of? It is made up of the lip and then gingiva. So you should have it in mind about the lip and the gingiva. What is gingiva is related to your teeth related to that, and this is the gingiva. And buccal mucosa, whatever is the cheek mucosa that is there over here, this side and this side. And you should have in mind about the hard palate that is there over here. And you should have about the tongue that is there over here. This is the floor of the mouth. And you should have anterior two-thirds of the tongue also. So when you take this foramen cecum, this is the anterior two-thirds of the tongue. So when you open your mouth like this, so you put your tongue like this outside, the anterior two-thirds of the tongue, and here will be your hard palate to soft palate junction. Here will be your soft palate, that is a different issue. So you should have the anterior pillar here, and then you should have a line joined from distobuccal aspect of the third molar till the level of this particular third molar below. So whatever it is, so third molar till the level of third molar, this will become the retromolar trigone. Anteriorly will be the buccal mucosa. Anterior will be the buccal mucosa. So these are all structures, including the lip, the gingiva, etc., etc. All these will form the oral cavity that you should have it in mind. Number one is the lip. Number two is the gingiva. Number three is the buccal mucosa. Number four is the hard palate. Number five is the floor of the mouth. Number six is the oral anterior two-thirds of the tongue. So 1, 2, 3, 4, 5, and 6. Almost 6 structures that are there. Is all become your oral cavity. You should keep it in mind about all these things. This is very important. Just I have revised only for the sake of understanding the things. So you can understand the things like that. And after this,
Lip. Imaging has little role to play in early lesions, which may not be distinguishable from the normal orbicularis oris muscle. The margins of more advanced infiltrative lesions may be defined more readily with imaging. Bone erosion, which usually occurs along the buccal surface of the mandibular or maxillary alveolar ridge, is best detected with CT. Once tumor gains access to the mandible, there is the potential for perineural spread along the inferior alveolar nerve. The presence of bone erosion upstages these lesions to T4 and necessitates bony resection. The lymphatic drainage is to level 1 nodes, that is submental and submandibular, and level 2 nodes.
so you should keep in mind once again about these things which you are getting right now is about our lip. So very little role the lip is having. It may not be distinguishable from the normal orbicularis oris. What is the muscle that is there present in the lip? Is the orbicularis oris muscle. It may not be distinguishable from normal orbicularis oris muscle. So you might have to palpate it also sometimes. And sometimes infiltrative lesions may be defined more readily with imaging. So infiltration, whenever there is a infiltration of the mandible, for example, like this, it is defined by imaging. Next, the bone erosion which occurs along the buccal surface of the mandibular or maxillary alveolar ridge. Mandibular or maxillary alveolar ridge is detected by CT scan. I already told you this is the alveolar ridge wherein the teeth are present, sockets of the teeth are present. You can call it as alveolar ridge. So that one you will be able to see with the help of CT. Once the tumor gains access to the mandible, there is a potential for perineural spread. You should have it in mind. Potential for perineural spread through the inferior alveolar nerve. Through the inferior alveolar nerve, you have the potential spread through the inferior alveolar. As you know, that inferior alveolar nerve branch of the mandibular division of the trigeminal nerve. Inferior alveolar nerve, it can help in the spread. Bone erosion, if it is present, it goes for T4. So bone erosion in a lip cancer, it is T4. T4 you should have in mind about the bone erosion. Bone erosion, if it is present, it goes for T4. Very important. You should keep it in mind. So bone erosion leads to T4. If it is there, you have to go for bony resection. You have to go for bony resection. And next one is about the lymphatic drainage to level 1 lymph nodes, such as submental and submandibular. So 1A being submental, 1B being submandibular, and level 2 lymph nodes also you should be keeping in your mind so that you can remember that, and that way you can understand this lip cancer with the help of this slide.
Floor of the mouth. Imaging is used to assess the presence of bone erosion and tumor size, which may clinically be underestimated if there is submucosal extension. It is important to determine the relationship of the tumor to the midline septum and to the contralateral neurovascular bundle, since this will alter the treatment. Midline spread may occur directly across the genioglossus muscle, and midline septum or occur via the potential space between the genioglossus and geniohyoid muscle.
So again, we have a lot of things to understand over here. So in this, what we have to think is about our muscles. So imaging of the floor of the mouth. This is the floor of the mouth, as you could see here. So what would you imagine for the floor of the mouth? This is the mandible, and this is the alveolar process that you have got over here, and this is the tongue that is over here. Tongue is made up of GHSP, so genioglossus, hyoglossus, styloglossus, peltoglossus, and superior, inferior, transverse, and vertical muscles. So these are the extrinsic muscles of the tongue, and these are the intrinsic muscles of the tongue. So this should be kept in mind. And when you are having a tongue, you have got a frenulum. When you lift the tongue, you have got a frenulum like this. So that is a midline septum, acting as a midline septum. Once again, imaging is for bony erosion and tumor size. So because of submucosal extension, you may not be able to see it completely. You may not be able to see it completely. That is a submucosal extension. Submucosal extension that you can have. Submucosal extension that you can have. So that should be done along with the CT or MRI. You will be able to see that. So determine the relationship of the tumor. You have to know the relationship of the tumor with the midline septum to the contralateral. If the midline septum, this one is crossed like this, you have got contralateral neurovascular bundle. Contralateral neurovascular bundle, and this will be altering the treatment. So contralateral neurovascular bundle, which will alter the treatment. So midline spread, whatever is there, it can occur across the genioglossus muscle. So you know the genioglossus muscle, number one, and midline septum or via potential space between genioglossus and geniohyoid muscle. So between genioglossus and geniohyoid. So genioglossus and geniohyoid muscle. So where is the genioglossus muscle? It's a genial tubercle from here to here, and geniohyoid it is go down. So the space between the genioglossus and geniohyoid muscles can be helpful for spread of the tumor. The genioglossus and geniohyoid muscle can be helpful for spread of the tumor. You should be keeping in mind all these structures there over there.
Ill-defined tumor margins, invasion of the sublingual space, and proximity of tumor to neurovascular structures are highly suggestive of neurovascular involvement. Tumors with a mean diameter of 2 centimeters or greater are also more likely to invade the neurovascular bundle. These patients are at greater risk of cervical nodal involvement. Thin section CT is again the imaging modality of choice if bone involvement is suspected. Example, fixed lateral floor of mouth tumors, but otherwise MRI may give more information about the tumor, especially if there is artifact from dental amalgam.
So you are having this artifact from dental amalgam, as you could see over here. So next, as you could see, ill-defined tumor margins. So tumor margins are very important for us. Margins of the tumor are very important for us because this will say that how it is going to be having an invasion. Okay, and based on that, an invasion of the sublingual space, very important, and the proximity of tumor to the neurovascular structures. Neurovascular spread is the rapidest spread you can have, suggestive of neurovascular involvement. Whether there are blood vessels that are involved, whether there are nerves that are involved, are very important as far as this understanding is concerned. So tumor with a mean diameter of 2 centimeters or greater. So 2 centimeters or greater than this mean diameter, they are likely to invade the neurovascular bundle. So whenever there is a 2 centimeters or greater, that is, it becomes minimally T2. Okay. So T1 is less than 2 centimeters. T2 is 2 to 4 centimeters, as you have in mind in that concept. So these patients are at greater risk of cervical metastasis. So whenever greater than T2 or whenever greater than 2 centimeters is 2 to 4 centimeters, you have got lymph node metastasis can be higher in that. So because of that, only thin section CT scan is again the imaging modality of choice. So any bone involvement, you have to go for CT scan. You have to go for CT scan in case of bone involvement. For example, fixed floor of the mouth, lateral floor of the mouth tumors, if they are fixed to lateral part, you can go for it. MRI can give rise to more information about tumor, especially if there is dental amalgam. So you have to go for MRI in case of dental amalgam. In case of dental amalgam. So MRI in case of dental amalgam. If you don't have that, you have to go for dental amalgam. MRI should be done in case of dental amalgam involvement, and this bone involvement, especially the CT scan is enough. So CT should be done for bone involvement. You should keep it in mind. CT scan should be done for bone involvement. I hope you are able to see the annotation, madam.
The
Yes.
primary tumor is often
Continue.
the primary tumor is often seen well on unenhanced T1 weighted MR scans, and tumor involvement of the normal marrow is also well demonstrated by this imaging sequence.
So as you could see here, you can understand about the primary tumor is well on unenhanced T1 weighted MR scans, and tumor involvement of marrow is demonstrated. So marrow can be demonstrated by T1, as you could see here in this picture, this particular picture. So T2 weighted A and T1 weighted MR. So this is the T1 weighted MR, magnetic resonance images of the anterior floor of the mouth. That is a solid arrow. So this is T1 weighted MRI and then T2 weighted MRI. So T1 and T2, you can be helping even without enhancement. You can see the normal marrow. So marrow involvement can be seen in this. So as you could see, the marrow involvement also can be understood.
The periosteum does
Hello. Hello.
sorry sir.
Yeah, please.
Hello sir.
Yeah, please.
The periosteum does provide a barrier to tumor infiltration, and tumor may gain access to the marrow via tooth sockets in edentulous patients. The specificity of MR imaging has been shown to be significantly lower than that of CT in the assessment of marrow invasion. A prospective study using the MR detection of tumor signal replacing hypointense cortical rim as the main radiological finding for mandibular invasion had high accuracy, that is 93%, and sensitivity 93%, and specificity 93%.
So you should keep it in your mind about these things also. Like periosteum provides a barrier to the spread. Periosteum provides a barrier to the spread, and tumor gains access via tooth sockets. So the marrow, it can go via tooth sockets. You can go by tooth sockets. Are you able to see the drawing? Hello?
Yes.
You're able to see the drawing? I'm
Yes,
drawing.
sir.
Yeah, okay, fine.
Yes, sir.
Okay. The specificity of MR imaging. So you should have in mind about the MR imaging, which is significantly lower than of CT scan in marrow invasion. So when you take marrow, so you have got MRA as a low specificity. So specificity is lower for MRA as far as CT scan is concerned. So marrow invasion, CT scan is better according to this statement. CT scan is better for marrow invasion. CT scan is better for marrow invasion, as you should keep it in your mind. And then detection, MR detection of tumor signal replacing the hypointense cortical rim in mandibular invasion has got 93% accuracy, 93% sensitivity, and 93% specificity. So what should you think here? MRI detecting the hypointense cortical rim. So cortical rim is hypointense in this situation. So MRI to detect that, you will have a 93% rate. So but whereas in this marrow, sometimes CT is better than MRI. According to this, a bit controversial statement. We can think later on. Next.
Another group 30, however, found that although MR was sensitive, it had a poor positive predictive value for mandibular invasion. In a further study, 99MTC single photon emission computed tomography, which is a radioisotope technique, correctly predicted mandibular invasion in 11 out of 12 cases with no false positives, and CT only 3 out of 12. Posterior spread can occur along the mylohyoid muscle, and tumor can thus gain access to the deep facial spaces of the neck.
So when you take, once again, the otherwise the one more study, like MRI is sensitive, even the minute test also it can know, but poor positive predictive value for mandibular invasion. So sensitive investigation, but poor positive predictive value. So it is very less, okay, for MRI. And one more study has shown that technetium 99M SPECT, single photon emission computerized tomography. So with technetium 99M, it predicted the mandibular invasion in many cases, most of the cases, whereas CT scan is only 3 out of 12 cases according to the experiment. So technetium 99M SPECT is the best for your mandibular invasion, as you could see. And posterior spread is through the mylohyoid muscle, and it can access is gained through the facial spaces of the neck. The access can be gained through the facial spaces of the neck. The access can be gained through the facial spaces of the neck.
Tumor can also extend posteriorly to involve the tongue base. Obstruction of the submandibular ducts will result in the dilation of the ducts and probable enlargement of the affected gland, which can be mistaken clinically for a nodal mass.
So tongue base can also be involved by the tumor in the oral cavity. And submandibular gland ducts can be obstructed. They cause dilation of the gland, and then it leads to enlargement of the gland, which can be seen, and sometimes we feel that it is a nodal mass. This should be kept in mind. Sometimes it is a masquerading feature. And in this particular picture, axial still imaging showing bilateral submandibular gland duct obstruction. You could see this is the duct, as you could see. The duct obstruction could be seen here, this particular picture.
The depth of tumor invasion is related to the probability of nodal spread. The lymphatic drainage is to nodes in level 1 and 2.
So depth of the tumor invasion is very important for nodal spread. Depth of the tumor is important for nodal spread. Very important point. Depth for nodal spread. Next, lymphatic drainage for oral cavity is 1 and 1A, as you know that. So if you take this one as the mandible, you have got, as you know that, so this is the hyoid bone here, and you have got the anterobilium digastric and posterior digastric like this. So this is a mastoid process as you have it here. So this is the underbelly of digastric, and this one becomes the center midline of the neck. This is the mandible as we have already seen. So this one becomes like 1A of this side and 1B of this side. This is submental. So 2 to 5 nodes will be there in the submental region, as you should know here. And 1B is the submandibular region. So submandibular region. Submandibular region. So this is the submental region. Submental region. Submental region. You should be keeping it in mind. So I think, hello.
Sir.
Thank you very much for participating
Okay,
in
sir.
the radiology discussion of ENT students. Thank you very much. We'll meet in the next
Thank you.
lecture later.